Well, good afternoon or good night. It is a pleasure to be here today, so thank you, Eva, for your introduction, and thank you, NanoString, for preparing this symposium. So in the next 20 minutes, I will try to give you a broad overview of the value of the intrinsic subtypes, the current value, and the current clinical utility, but also, and most likely, what's coming in the future, in the upcoming future. So let me see. These are my disclosures. So the story of the intrinsic subtypes is not new, as you probably know. It's a story of now 18 years almost, when Chuck Peru, when he was at the University of Stanford, published this seminal work, at that point with only 40 breast samples and homemade microarrays, showing that by looking at global gene expression analysis, looking at thousands of genes and its expression, one could classify breast cancer into different molecular entities. This discovery, again with only 40 breast samples approximately, is now considered a major research advance for breast cancer by the American Society of Clinical Oncology. It's been, as I said, 18 years, and many more samples now have been profiled. Now we're talking about thousands of samples being profiled. Technologies have improved. They're not homemade anymore. And also analytical tools have improved a lot. But at the end of the day, we pretty much identify the same subtypes that Chuck described in year 2000, basically the two luminal subtypes, the luminal A's and luminal B's, the so-called HER2 enriched, and the tumors that are usually triple negative, the basal-like, and the Claudin low. Here in this slide, I'm using it to make 2 points. One is that these entities are not classified or not identified using just 1 or 2 or 3 biomarkers. These entities are defined by an entire profile defined by a certain number of genes. Actually, in the original publication, one needed at least 2,000 genes to identify these entities. So 1 or 2 biomarkers will not be able to identify these entities. And the other thing is that you're probably asking is how come 18 years have gone by and we're not using this in the clinic. We're starting now, of course, but it's been a lot of years. Well, technology has not been there. As you know, microarray technology required fresh frozen tissue, which is not always available at our setting. Microarray technology requires resources, and microarray technology requires also a lot of analytical tools. And as you know, when we are in the clinic, we need to make decisions as soon as possible. So with these 2 points, things definitely changed in the last years. On one hand, we don't need now 2,000 genes to identify these entities. Chuck Peru and his colleagues showed that by looking at 50 genes, one could identify these entities defined, again, with microarrays and with 2,000 genes. So good news, with 50 genes, we can identify these entities. And the other thing that appeared is the technology. Technology improved, and today we have a technology like the one shown here, the nCounter platform, that allows to run gene expression in an easy manner, let's say, at your local lab. Everything is practically automated, and to me, the most important thing that is that there is no enzymatic reaction, and that makes the assay very reproducible, as has been shown, and has been also validated by the FDA. At the same time, the platform allows, as you can see here, to do research, which we all like to do, clinical trials, retrospective analysis, and at the same time, as you know, the PAM50 assay today is commercialized under the name Prosigna, that on one hand gives you the subtype, but at the same time predicts the risk of relapse at 10 years, and also it gives you information regarding late recurrence. So for many years, the community has thought that, again, with 2, 3, 4 IHC-based biomarkers, Ki67, ER, PR, HER2, one could classify these entities and recapitulate these entities, and that was it. I do believe that now, in 2018, we can conclude that this is not true. Here you can see a combined analysis of different data sets. You can see thousands of samples where we have intrinsic subtyping and IHC data. And as you can see that in the 3 clinically, let's say, relevant groups, hormone receptor positive, HER2 negative, HER2 positive, and the triple negatives, all the intrinsic subtypes can be identified. It is true that they are identified in different proportions, but they all can be identified. And what is clear is that within hormone receptor positive, HER2 negative, these entities, in my opinion, have reached clinical utility, as we will see. It's true that the vast majority are either luminal A, luminal B, but be aware that some non-luminal tumors will be identified, around 8% are expected. So I say that they have reached clinical utility because today, if we identify this group of luminal A, low proliferative, these are the group of patients that do not need chemo. This has now been shown across many different studies. Today we'll review the data. This is just an example of a study showing that by looking at gene expression analysis, looking at this low proliferative luminal A, we can identify this group of patients that without chemo, just 5 years of endocrine therapy, we can pretty much be assured that they are cured. One important aspect that we've learned over the years is that gene expression analysis by itself is not enough. If we are to predict prognosis, we need to integrate that with tumor size and nodal status. And I don't know of anybody who can really integrate these three data types together in their minds into a single score. Our minds are not ready for that. Therefore, we need algorithms that at the end of the day gives us a final score of the prognosis of that patient. And that's what the ROR is, which integrates biology, intrinsic subtype information, tumor size, and the nodal status is used as the cut point to define risk. This is just an example of what I also call precision medicine or individualized medicine. This is a patient, 65 years old, postmenopausal, with a tumor of 2 centimeters, node negative, with a grade 2, ER 80%, PR 90%, HER2 negative, with a Ki67 that is not very low. It's like, call it intermediate, Ki67 at 15%. And here, when we do the assay, we know on one hand it's a luminal A, but on top of that, we can predict the prognosis of that patient, and in this case, 40 points would mean a risk of relapsing, meaning relapse at distant sites of 3% without chemotherapy, just with 5 years of endocrine therapy. Probably we all agree in that case that chemotherapy is not needed, and even if it's given, things would not improve much, and toxicity would definitely be an issue. But this is in the context of node-negative disease, where definitely these and other assays are showing clinical utility. I do believe that in node-positive disease, there's also clinical utility in this regard. More and more often, we are diagnosing patients with node-positive, but more than node-positive, sometimes it's only one node-positive. This happens in the clinic. The question is, can we use these assays in this particular context? I do believe so. We have data like this one recently published. We also have data in the TransAttack and the ABCG08. This is the most recent publication in the Danish trial, showing that even in patients with one positive lymph nodes, if they are low risk by ROR, this group of patients have a very low risk of relapsing at 10 years without chemotherapy. As you can see here in this study, 3.3% relapse rate at 10 years. So I do believe that even in this group, we can feel comfortable to not give chemotherapy. This is just an example of this particular setting, a 60-year-old woman with a tumor of 1.8 centimeter, one positive lymph nodes, grade 3, ER 90%, PR 70%, HER2 negative, with a Ki67 again intermediate. In this case, we would doubt, I would doubt whether to give chemotherapy or not. The assay in this case gives me the subtype and a risk of 6% at 10 years. This information together, of course, with many other information that we put onto the table when we talk to the patient, allows us to make a better decision. So this is prognosis, and prognosis has shown clinical utility both in node-negative and in node-positive disease. What else do we know about intrinsic biology? Well, in one hand, we know that there is a particular group of ER-positive, HER2-negative tumors that are highly chemosensitive, and these are the non-luminal that I referred to before. These are two studies, independent studies, two neoadjuvant trials or neoadjuvant cohorts, all hormone receptor positive, HER2 negative, and all these patients receive anthracyclines and taxanes in the neoadjuvant setting. And as you can see, these are the responses in the neoadjuvant setting. It's true, we're not talking about survival here, we're talking about PCR or residual cancer burden. And as you can see, the luminal A's show the lowest response on the left, 5% PCR rate, followed by the luminal B's, and the basal likes 36%, and the HER2 enriched 16%. And pretty much you see the same in the other study. So I do believe even within hormone receptor positive, HER2 negative disease, identifying the basal likes, for example, this is definitely a group that needs chemotherapy. As you can see, the response rate are the classical response you would expect in a triple negative basal-like tumor. So this, I would argue, this is a predictor of chemosensitivity. At the same time, you see the luminal B's. The luminal B's have an intermediate response between the non-luminals and the luminal A's, 15% PCR rate or RCB01 of 20%. This group of patients, in general, I would argue they need chemo, especially the high-risk luminal Bs. But potentially in this group, we could find strategies to get rid of the chemo if we add other drugs. For example, CDK4 and 6 inhibition. And this is actually what we're currently doing at Solti. We are now recruiting in this study called the Coraline trial. This is a phase 2 randomized neoadjuvant study in postmenopausal, hormone receptor positive, HER2 negative, where we select patients based on PAM50, luminal Bs. They have to be luminal Bs by PAM50. On the bottom in this circle plot, you're seeing the screening that we've done so far, 91 patients. In this trial, you can see that the majority are luminal Bs, so this is working, but there is a 30% luminal As, and once again, we are identifying this, in this case, 5% of non-luminal tumors by doing this analysis. So these tumors are there and they're real. So we're only selecting luminal Bs and randomizing them to standard chemo, AC followed by Taxol, or a strategy of no chemo, in this case letrozole ribociclib, for 6 months, and then we're doing surgery with the primary endpoint being PAM50 ROR low disease, so ROR low risk. So basically we want to take these tumors that are either intermediate high risk to ROR low. So moving from early disease, where there is a lot of data, in the metastatic setting we have less data, but I think we're getting data that might show that intrinsic subtyping is clinically valuable. This is one particular study that was published in 2009 by Stephen Johnston, a first-line ER-positive trial where patients were treated with letrozole plus minus lapatinib or placebo. This was a phase 3 pivotal study of 1,286 patients. The study showed that in the HER2-positive subset, lapatinib did have an effect, but in the HER2-negative, there was no effect of lapatinib. We had the opportunity to send the samples to my lab, and using the Encounter platform, we did intrinsic subtyping, blinded from clinical data, and the results are here. Here I'm showing you the result in the HER2-negative subgroup. And as you can see, intrinsic subtyping in this particular first-line setting is highly prognostic in those patients with letrozole only. You can clearly see that these non-luminal tumors behave quite poorly. The median PFS to just letrozole was around 4 to 5 months. The luminal As, just with letrozole, had 18 months median PFS, and the luminal Bs, 11 months median PFS. And actually, we showed that this is independent of any other clinical pathological variable that you can think of, and also in terms of overall survival, on the right, the same thing. So definitely here we have a biomarker that from a prognostic point of view might help us select which patients maybe we could treat with just endocrine therapy, and maybe those that need the chemotherapy in the first line setting, a question that we have every day in daily clinical practice. The other observation of this trial had a randomization to lapatinib, an EGFR HER2 TKI. So we could test the value of lapatinib in the subtypes, especially in HER2-negative disease. And we did this observation that is very preliminary, hypothesis generating, but I think it's very interesting, and that is that in the ER-positive HER2-negative non-HER2 enriched, there was no benefit of lapatinib. However, in those tumors that are HER2 negative by standard criteria, but they are HER2 enriched by intrinsic subtyping, we did see a benefit of lapatinib. And actually, even the interaction test was significant with a small number of patients. Again, hypothesis generating, but suggesting that maybe these tumors are driven by the EGFR HER2 pathway, and in the future, a TKI against these tumors could be a strategy. So there is more data in the metastatic setting. Actually, this is coming from independent investigators. Actually, this is data from Pfizer that they produced from one of the pivotal trials that led to the approval of palbociclib in the first-line setting with letrozole, the PALOMA-2 trial. This was a study of 666 patients, and they profiled 68% of the samples, 455. You can see the distribution of the subtypes, and you can see that the majority were luminal A, there was luminal Bs, 30%, but I would point out to these 20% of non-luminal tumors that were identified, despite all these tumors being ER-positive, HER2-negative, so a very interesting finding. But most interestingly is when they look at the association with prognosis and benefit from palbociclib, I think to me this is quite striking. On one hand, from a prognostic point of view, they basically showed the same thing we showed in the EGF 3008. The luminal A's have the best median PFS, in this case 17 months. The luminal B's 11 months, the same thing we saw, 11 months. Here the HER2 reached 11 months, a little bit higher than what we saw. We saw 5 months, and there were 2 patients with basal-like disease that progressed very fast. But apart from a prognostic point of view, which they replicate our results in the EGF 3008, what's interesting is the randomization to palbociclib. And here you can clearly see that the benefit of palbociclib is restricted mostly to the luminal A's and the luminal B's, where we clearly see an increase in median PFS. If you look at the HER2-enrich, and of course, despite the low number of patients, you can see that there might be an increase, but this is, in absolute terms, very small. It's less than 3 months, thus suggesting that this group of tumors, not only they are poor prognosis, they're associated with poor prognosis, but they might not benefit from CDK4 and 6 inhibition. Of course, this is one trial, this not changes clinical practice, but if further studies show that, I think here we might have an assay that can identify 20% of the patients that do not benefit from a CDK4/6 inhibitor, which could be important. So moving from hormone receptor positive, HER2 negative, I'll briefly touch on HER2 positive disease, where clearly you can see that the distribution of the subtypes is quite substantial. It's true that the HER2 enriched represents the vast majority, but again, expect luminal A's that are HER2 positive, luminal B's that are HER2 positive, and even basal likes that are HER2 positive. So over the years, we've learned that among the different intrinsic subtypes within HER2 positive disease, those that are HER2 enriched by gene expression are the ones showing the highest response to anti-HER2 based chemo. And this has been shown here in 2 retrospective analyses of 2 prospective trials, the NeoAlto and the CLGB. These are 2 very similar studies with taxane, trastuzumab, and the addition of lapatinib. Similar picture, and the PCR rate in the HER2-enriched overall was almost 60%, whereas in the others was 29%. And even the difference between HER2-enriched and basal here was significant, so which I think is quite interesting, despite all these tumors in general being hormone receptor negative. So this is in the context of chemo, and this was already published. We recently reported new data in San Antonio, and this is data from the Christine trial that you probably are aware. This is also a neoadjuvant trial, HER2 positive, defined by standard criteria, and these patients were randomized to a strategy of T-DM1 pertuzumab in the neoadjuvant setting, or let's say a common regimen, which is docetaxel, carboplatin, trastuzumab, pertuzumab. Patients then underwent surgery, and they continued with the treatment afterwards. In Lancet Oncology last year, Sarah Hurwitz reported the data at surgery, so the PCR data. So thanks to a collaboration, in this case with Roche and Entech, we were able to profile 80% of the samples, the baseline samples from this trial, 354 samples. Here you see the distribution of the subtypes, which once again looks pretty much what I showed you before. The vast majority are HER2-enriched. We see basals, we see luminal A's, we see luminal B's. And on the right, you see the PCR rates in both arms. We can clearly see that the HER2-enriched achieves the highest PCR rates, between 60 to 70%, and there's not much difference between the two arms. The luminals A and B have lower PCR rates overall, and no difference between the two arms. And the basal likes, I would like to point out the basal likes here, despite the low number of samples, again 26 patients, you can clearly see an effect in the sense that those basals that receive docetaxel and carboplatin achieve higher PCR rates, actually 70%, whereas the T-DM1 pertuzumab did not achieve that high amount. And I think this is due to the chemotherapy sensitivity of these tumors. These tumors need chemo, and T-DM1, despite having chemo, is not enough. In a multivariate model, PAM50 predicted PCR independently of all other clinical pathological variables, and actually hormone receptor status lost its significance in the presence of intrinsic subtype, and even the interaction test was significant. So all of these studies I showed you was in the context of chemo, so it's very hard to discriminate or understand the chemosensitivity of the HER2-enriched versus the anti-HER2 sensitivity, so because we're giving both drugs together. So another way to discern that was to run a trial like this one, where we basically treat patients with just dual blockade, HER2 blockade, no chemo, just to test the anti-HER2 sensitivity of the intrinsic subtypes, and in particular the HER2-enriched subtype. This is the Pamela trial that we published last year in Lancet Oncology, a study that we performed in Spain by Solti, a HER2-positive study where patients received trastuzumab and lapatinib for 18 weeks without chemo. Patients did receive endocrine therapy if the tumor was hormone receptor positive. Surgery was performed, and the study was powered to test a hypothesis that the HER2-enriched would achieve the highest PCR rate, because we thought these are the group that are more HER2 addicted, whereas the non-HER2-enriched, the PCR rates would be less than 10%, with a difference, a delta of 27%. So the trial was reported. On one hand, on the left, we show the distribution of the intrinsic subtypes as expected as before. And here we'd like to point out that HER2 was done in a central lab under the highest accreditation you can get for HER2, so the ISO 15189. So these were HER2 positive for sure, and you get this distribution. And regarding PCR, we met the primary endpoint, the HER2 enriched without chemo, just dual blockade, achieved almost a 41% PCR rate versus 10% in the non-HER2 enriched with a delta of 30%, so above 27%. That's what we expected. Again, this does not change clinical practice tomorrow, but it opens the door to try to explore strategies of just anti-HER2 treatment without chemo in different settings and with a particular biomarker. So the take-home messages of my presentation are as follows. On one hand, PAM50 ROR can help identify patients with hormone receptor-positive, HER2-negative, luminal A early disease who do not need chemo due to their low risk of relapsing at 10 years, both in the node-negative disease and node-positive disease. Subtype predict chemotherapy sensitivity in hormone receptor-positive, HER2-negative in the neoadjuvant setting and independently of the other variables, including age and menopausal status. Also, I've shown you that subtype predict prognosis in the metastatic setting in hormone receptor-positive, HER2-negative in the first line, 2 independent studies showing that. And potentially, the HER2 enriched within this group that are HER2 negative might be targeted tomorrow with anti-HER2 therapy if further evidence is built. And this group of tumors might not be treated with CDK4 and 6 inhibition because they don't benefit if further evidence is shown. Subtype predicts anti-HER2-based treatment sensitivity within HER2-positive disease, and you've learned this morning with Martin Picard, Lisa Carey, really pointing out that we need to divide HER2-positive disease into different subtypes and tackle HER2-enriched disease as a different entity. And at the end of the day, we need further studies that we and others doing to really show the clinical utility of this biomarker. Thank you very much.